Hi, my name is Nikki Schultek. I'm the founder of Intracell Research Group, and today I'm hosting a series of discussions called Brave Scientists, in which I invite individuals who do paradigm-shifting work in science and medicine to talk about concepts that have the ability to shift the way we think about chronic diseases. Today, I'm honored to introduce you to Dr. David Hahn. David is a family practitioner with special training in epidemiology, immunology, as well as medical microbiology. David is the author to over 50 publications and chapters on the relationship between infectious agents and asthma, with particular interest in chlamydia pneumoniae infection, which is a respiratory bacterium. David is here with us today to talk a little bit about asthma and the concept of asthma possibly being driven by underlying chronic infection. David, it's a pleasure to have you here.
Thank you, Nikki. It's great to see you today.
So I guess we'll just start off with the first question that comes to mind, which is, how did you begin to think about asthma as an infectious disease as opposed to a purely autoimmune condition?
Well, it happened by complete serendipity. I began practicing quite a while ago in the 1970s, which is, when I think about it, quite a while. And I was not particularly interested in asthma necessarily, but I had an interest in infectious diseases, and especially respiratory illnesses in primary care. And my first practice situation was with a group of physicians in Madison, Wisconsin, some of whom were kind of old-fashioned. And whenever a patient would come in with any kind of respiratory illness, they'd pull out a syringe of penicillin and give them a shot. That was pretty much standard practice back then. And being newly trained, I had been told that was not appropriate because most of these were viruses, and it just went against my grain. But this fact was that when my partners were off duty and I was seeing their patients, I had to do something to satisfy their needs, but I just couldn't bring myself to give them penicillin. And most of them were not particularly interested in getting nothing. So I sort of made a compromise and gave them an antibiotic called erythromycin, which is effective against a bacteria called Mycoplasma pneumoniae. We knew that that was a cause of respiratory illnesses, so it was plausible that perhaps it might work in some cases. And although I didn't really believe that, but it sort of made things go smoothly with these patient encounters. And so over time, I started seeing people who clearly responded to treatment. But after they stopped the treatment, their respiratory illness would come back again. And I'd give them another treatment and then it would go away. So it was, something was going on, but we didn't really know what it was. That was sort of piqued my interest. Was there some sort of unknown bacteria out there that I was sort of treating without really knowing what I was doing? And turns out that's probably what happened, because in 1986, an epidemiologist named Tom Grayston wrote an article in the New England Journal describing a new bacteria that he called TWAR, T-W-A-R. It was an acronym for this newly described chlamydial organism, which later became known as chlamydia pneumoniae. So I started researching that as it applied to respiratory illnesses. I wasn't thinking about asthma at all. So I contacted an immunologist at the State Lab of Hygiene in Madison, where I practiced in Wisconsin. And he graciously collaborated, got the testing going. And I worked with about a dozen of my practice partners around Dane County in the Madison area. And we ultimately enrolled 450 patients. We reported on 365 of them in the New England Journal, and essentially was able to show that this bacteria did indeed cause bronchitis, which is just a coughing illness, and but pneumonia, 10 to 20% of community-acquired pneumonia. But those facts were really secondary to something that we stumbled upon quite accidentally, and that was that many of these people with respiratory illnesses wheezed. Some of them developed asthma, and there was just strong associations between the chlamydial infection and asthma development. And when we looked at just the epidemiologic associations of antibodies with asthma, there was just very strong ties between having high antibody levels and having chronic asthma. So we proposed that this bacteria might be involved in both initiating the disease and in promoting the disease, in other words, causing it to become chronic. And that was published in JAMA in 1991 and made quite a splash initially. And I, being a family doctor, I thought, okay, my job is done. Now this will be taken up immediately by the asthma research community. They will research it and figure out, you know, is this right? And if so, you know, how much of asthma might be involved and so on and so forth. So I was very naive because basically after the hoopla died down, nothing happened.
So it wasn't this immediate aha moment for the whole community. You know, it was something that it was quite unconventional, obviously, and flew in the face of everything we think we know.
Yes, with the exception of a couple of researchers into chlamydia, one group in Italy led by Francesco Blasi,
Mm-hmm.
and another in New York by Margaret Hammerschlag, who they came at it from the point of view of infection. They had chlamydia labs. They were able to confirm some of the things we were saying, but among the larger asthma research community, this fell like a lead brick. And so I decided this was so important that somebody had to pursue it. So I spent the next almost 10 years, I spent 3 years reading up on asthma, which was something I hadn't really specialized in. Read all the epidemiology I could find and read the sparse amount of information from primary care where I practiced. And at the time, primary care research did not research asthma. It was very little, except from Great Britain. And then the large volume of evidence from the asthma research community. And so I educated myself. I went back and got a master's degree in epidemiology and some advanced research training in medical microbiology and immunology and clinical trial design. And then I launched a series of studies in my practice and then around the US in terms of clinical trials, which unfortunately were small because they were underfunded. But we gradually built up evidence that all of which was consistent with the original idea that this infection could both initiate some cases of asthma and then cause it to become chronic.
So, you know, over the last few decades, a lot of publications, you know, have come out along these lines, right? Addressing studies of, you know, patients' lung tissue, lung fluids, studies looking at blood, other studies looking at treating asthma and other respiratory diseases, leveraging antibiotics. So for you, what is the most compelling piece of evidence or few pieces of evidence that make you feel like this is something that you wanted to spend, you know, the better part of a few decades pursuing and
Right.
you know, continuing to champion in the face of, you know, a very challenging concept to alter?
I think coming at it from the point of view of a primary care physician, I cared most about making people better. So seeing that people with asthma could be treated and some even um, cured with antibiotics was the primary reason that I pursued this, because in my very first work, came across, for example, a woman who was in her, I think she was about 45. She had never had any respiratory illnesses. She got a bronchitis, which with wheezing, and it developed into severe asthma that was not responding to treatment. And after a while, and because we were able to show she had a chlamydia pneumoniae infection, I then treated her with some antibiotics, in this case, tetracyclines, the first case I ever treated, and her asthma disappeared. And that was the kind of aha moment for me, that here was a disease that was thought to be incurable and chronic. And I thought I had probably saved this woman a lifetime of unnecessary treatment by giving her 5 weeks of an antibiotic.
And that was just going to be my next question to you was, people listening will probably be thinking, well, I have asthma and I've been treated with antibiotics over the course of my life. Why would that, a week to 10 days of antibiotics not clear up my asthma? And so I figured I'll just throw that out to you.
Okay. Since then, I have talked to literally hundreds of people who have exactly that question. But in fact, many people contact me because they did get that week or 10 days of antibiotics, usually what's called a Z-Pak, which is azithromycin for 5 days, which actually stays in your system for about 10 days. So that's your typical 10-day treatment. And these are folks with asthma who noticed that after getting a Z-Pak for whatever reason, usually probably inappropriately for a viral illness, the asthma got better for 2 or 3 weeks. And then it came back. And the typical story I hear is they went to their doctor and reported this, and the doctor either ignores it or says, well, it was probably an anti-inflammatory effect. And the typical person accepts that until the next time they get a Z-Pak, it happens again. And this time they go online and find me, and we communicate. And my recommendation is you need a course of treatment, 3 to 6 months perhaps, because once asthma is established, and if it is hypothetically caused by a chronic chlamydial infection, these infections do not respond well to just short courses. They have to have long courses of antibiotics. And so for various reasons, which we could get into later. But so after 3 to 6 months, many of these folks will have a prolonged remission in their asthma.
Which is fantastic. So this year, one of the things that has happened is that azithromycin, so the drug that's a part of the Z-Pak that you mentioned, azithromycin, the macrolide antibiotic, has been added as an option for patients that do not respond well to other conventional treatments for asthma, or perhaps for the severe refractory patients with asthma, added to all of the global guidelines as an option. And with that, why do you think there hasn't been a major shift toward thinking about microbial involvement in asthma with the addition of azithromycin to all the guidelines and with all of the evidence that's out there already?
That's a complicated question. I'll try to address a couple of aspects. One is that asthma is a syndrome, doesn't have a single cause. So to say that chlamydia pneumoniae causes all asthma would be completely incorrect. In my experience, it's one of many causes. It may actually combine with other things to create asthma. So it's only one factor. But I personally think it's a treatable factor for people who meet certain criteria. But in fact, one of the problems is how to decide who to treat with antibiotics, because they're not going to work for everybody. We don't even know what proportion they will work for. Although the focus on severe refractory asthma is a clue that that's one syndrome where this infection may be much more common than in milder forms of asthma. Another complication is that most specialists who research asthma, I think deep in their heart believe that azithromycin is working not as an antibiotic, but as an anti-inflammatory agent, just like other anti-inflammatories, because the current sort of definition of asthma is that it's a non-infectious inflammatory disease. A third component is that there is a general acknowledgement now in the research community that bacteria may play roles in asthma. They talk about something called the microbiome, which is the complete makeup of the human bacterial population, usually in the gut. But now we know there's bacteria that inhabit the lung as well. And so there are people studying the microbiome as it links to asthma. But the thought again is that it's not a specific bacteria, it's kind of the entire population that's the cause. And so most of the research that involves bacteria does not focus on a specific treatable species like chlamydia pneumoniae, or another candidate would be Mycoplasma pneumoniae, rather on the whole microbiome as it sort of affects the inflammatory response. I think there's a reluctance to sort of think simply here about the possibility that one organism might be responsible for a minority of asthma, but a defined part that it could be treatable. And then the fourth complication, actually there's 5 complications. The fourth is that it's very difficult to make a microbiologic diagnosis of chlamydia pneumoniae infection deep in the lung. In fact, it's virtually impossible with the techniques we have now. So that it's hard to study, and no one has ever definitively made a diagnosis in a living person's lung. And then the fifth complication is that the way we define asthma, and I think the best way to illustrate this is in 1991, that was the year we published our first paper in JAMA. That was also the year that the National Heart, Lung, and Blood Institute published its first guideline on how to manage asthma. And at that time, the experts saw asthma as an allergic disease and had very little or nothing to do with infection. And but it had a lot to do with inflammation. The mantra was the root cause of asthma was inflammation. And I think that's still prevalent today, that all asthma research basically, it's very descriptive in the sense that people look at the inflammatory cells in the lung or in the sputum and try to draw conclusions about the causes of asthma by what the inflammation looks like. And since I came to this from the infectious disease perspective, I see it differently. I recognize that infections like chlamydia pneumoniae start off being an acute infection, and if it persists, it's subacute, and then it can become chronic. And in each of those situations, the inflammatory cells look different. In other words, it's a dynamic process that can start with Believe it or not, some chlamydial infections start out with eosinophils, which are typically thought to be the cause for asthma. They also have neutrophils. In the chronic phase, they can have monocytes and other cells. So the inflammation is not a static characteristic of asthma if it were caused by an underlying infection. And so that the different perspectives leads to lots of difficulties in accepting, I think, the infectious possibility, because the researchers are coming at it from the opposite direction than I am. The way I describe it in a book I wrote was that if you look at the inflammatory cascade in asthma as a waterfall, and the waterfall represents all the inflammation that's in the system. Most asthma researchers are standing at the bottom of the waterfall with buckets of varying size, trying to stop it or catch it. And each one is successful in catching some of the water, but none of them have so far been able to stop the waterfall. That's why asthma is thought to be incurable. And from the infectious point of view, if there are one or a limited number of bacteria that are responsible for a significant amount of severe asthma, that requires going upstream above the waterfall and stopping it at the source.
Which isn't completely outlandish, right? I mean, given that certain inflammatory conditions are documented that they can be driven by an infectious process. It's just really taking, like what you're saying, is taking what you would think of in the context of infectious disease research or that mindset and applying it to something not traditionally thought of as an infectious disease, like a subset of asthma patients.
Yeah, that's exactly right. So that's where I'm coming from. I think there are some researchers who appreciate this. I mean, I think part of the problem is it's almost too good to be true. You know, people say this is it's too simple. It's just so naive to think that this condition or a certain amount of severe asthma could actually be so simple as to be caused by a single organism. Yet there are, examples of people whose asthma has been treated with macrolides who look like they're cured. The real questions are, how many of them are there? I have some colleagues who acknowledge that the existence of this syndrome, but they feel like it's a very rare syndrome. And they may be right. We just don't know what the proportion of asthma will respond, and that's why we need more and better research. There's another aspect to this too that I don't think I mentioned, at least explicitly, and that is that from the infectious point of view, this organism is known to cause chronic inflammation and scarring and lung damage, so that it's entirely possible that it could start out causing bronchitis and wheezing and then asthma, but then over years it could create lung damage that looks like what we call emphysema or chronic bronchitis or COPD. And I personally have seen people like this in my practice. So from the clinical point of view, it's plausible. And I have some evidence for that in some of my research. From the epidemiologic point of view, it's now recognized that infections, acute infections, often precede the development of asthma, and that asthma can evolve into something called the overlap syndrome, which is basically asthma that sort of becomes less active, but then morphs into something called chronic obstructive pulmonary disease. So that this whole idea that asthma and COPD are different entities may not be entirely correct. The epidemiology suggests that yes, there is a condition called smoking-associated COPD, the classic emphysema in the heavy smoker. There's sparse evidence that that's associated with chlamydia pneumoniae infection, although there is evidence for that. But the other syndrome is the asthma and COPD overlap, and there's better evidence that that is associated with chronic chlamydial infection. So it may be that the way we view these diseases, asthma and COPD, as completely separate diseases, may actually have constrained our ability to get at the truth, because in the asthma and COPD research world, it's absolute heresy to enroll asthma patients who smoke in a study because, quotes, they might have COPD. So all asthma studies on which the guidelines are based exclude people with asthma or the overlap syndrome, or with smoking or the overlap syndrome. And on the other end of the spectrum, all the COPD studies only include people who smoke and exclude anybody with any asthma. So they're studying the smoking-associated emphysema, which is definitely a big problem and needs to be studied. But there's a middle group that's been excluded. About 30% of people with severe lung disease that have a mixture of asthma and COPD are excluded from all the research that's been done. Now, some people recognize that, but so far they haven't done much about it. They're still being excluded. So that, to me, is a barrier to really understanding whether these two diseases are really different or whether they're just different manifestations of the natural history of an illness that evolves from one into the other. And if that's the case, that's a classic example of a potential chlamydial natural history.
Thank you so much. The perspective is just fantastic and leaves you with a lot of food for thought. And I wanted to mention too, in case anyone tuning in is a patient that suffers with severe asthma or asthma in general, that David authored a book, which is just a fantastic overview of his experience in treating asthma patients with antibiotic therapy, including mostly azithromycin. And that I'm very grateful for you taking the time to talk about, all of the research that you've done and, basically to ask some very important questions and highlight some important research needs going forward. So thank you for joining us today, David.
My pleasure, Nikki. Nice talking with you.
Thanks a lot. Take care.
Bye-bye. Bye-bye.
Bye.